he was very keen whether we are getting a bus to Assam or not.
No. That was my responsibility as the presidency. I have to see that. When I invited that, we have to see that.
No, we are happy about your sincerity.
I don't think it is that easy. Giri had managed it.
I think we can start.
Yeah.
I welcome all the faculty and the delegates who are attending. At the outset, I request our ISA Pudukkottai Secretary, Dr. Periyasamy, to offer the welcome address.
Thank you, sir. Thank you. Good evening. It's very glad to meet you all in this 38th IAC webinar program of Pudukkottai Budan. I welcome our academic chairman, Dr. A.L. Minachchandram sir, who is the backbone of this event. And because of his hard work and enthusiasm, proper guiding, we achieved this 38th program in this week. On behalf of ISA Pudukkottai, I once again welcome you all for this online ISA webinar program, Pudukkottai Budan. Pudukkottai Budan, Pudukkottai is a small city branch from Tamil Nadu. From the starting, we are conducting this program on the March 23rd onwards, 2022, and we conducted so many programs in so many headings. And today we are going to talk or having lecture about 3 topics. One is green OT concept for sustainable future, and next one is pharmacokinetics of volatile anesthetics, and third one is aldine Cassidy vaporizer. So for this, I welcome our past president and acting IACA president of Pudukkottai, Dr. Venkatagiri sir. I welcome you, sir. And for this 38th program, we are having here Dr. Lalit Kumar Raigar, senior professor and principal, Government Medical College, Sirohi, Rajasthan. As a chairperson, I welcome you for this 38th program, sir. Next, we are having 3 speakers. One is Dr. Madhusudan Bhatia, professor, Kasturba Medical College, Mangalore. So he is going to talk about green OT, concept for a sustainable future. I welcome you, sir, on behalf of ISA Pudukkottai. Next speaker, Dr. Sumesh T. Rao, professor, Kasturba Medical College, Mangalore. So he is going to talk about pharmacokinetics of volatile anesthetics. I welcome you, sir, on behalf of ISA Pudukkottai. And next speaker, Dr. Gaurav Sibant Satyavardhan, a resident, Kasturba Medical College, Mangalore. So he is going to talk about aldine Cassidy vaporizer. On behalf of ISA Pudukkottai, once again, I welcome you all for this 38th online ISA webinar program, Pudukkottai Budan. And one more thing, as you all know, our program is accredited by Tamil Nadu Medical Council, and they are giving credit points for this program, those who are attending this program. For that, 100 rupees to be paid to our account number is mentioned here. And your attendance, there is screenshot of your attendance and your email ID and your contact number. Those things has to send to this mail ID, isapudukottai@yahoo.com. Those things has to send to this mail ID, isapudukottai@yahoo.com. And the important thing is, on every anesthetist life, that is operation, that is a holy part in our life, in our professional life, and our presence is everywhere and every time is there. So a small poem about that. Operation theater. Maintain the sterilization of operation theater. Minimize the noise as low as possible. Remove the cloth and jewels. Retain your heart and soul. Remove your cloth and jewels. Retain your heart and soul. Cover the mouth or nose call your boss and nurse. Paralyze the patient before surgery. Permit the near normal function after recovery. Avoid arguments and unusual accidents. Always aim for achievement. Avoid arguments and unusual accident. Always aim for achievement. Monitor man, machine and material. Before surgery, monitor man, machine and material. Maintain dignity, discipline and divine nature. Good luck, knowledge and hard work. Good luck, knowledge and hard work. Golden words behind our success. With this, I thank you all for this attending this 38th ISA webinar program. On behalf of ISA Pudukkottai, over to our academic chairman, Dr. A.L. Meenakshi Sundararajan. Thank you, sir.
Thank you, Dr. Periyasamy. Dr. Suresh Kumar, our ISA president of Pudukkottai, is not able to join today because of the preoccupation with his family function. Now I request the past president of ISA National and forever president in our heart, Dr. Venkatagiri, to offer the opening remarks.
Thank you, Dr. Meenakshi Sundaram. President, in his absentia, Dr. Suresh Kumar, friends, Madhusudan, Sumesh, and Raigar sir. When I saw that, I felt very interesting to see that green OT concept, because earlier also, one or other meeting, I attended a class on that green OT, and he has taken a class, not Muslim, somebody else. So I thought today I should attend at any cost and switch on the TV in time. So really, because from disposable we are going to reusable and all, as I think he may be telling that in green OT concept, stopping this nitrous oxide and all, mostly required for practitioners who have not heard that recent things. PGs may be knowing that very well. It is more important, and it should be taught to the administrators, not only for us, because admin will not hear. If you say that, my administrator will say, why you want that, you are giving answer like this? No, they will not understand. Not only me, that even private hospital also, they will think that we have to carry this, and it should be more and more taught. These 2-3 things which I was telling that in ISA also last time there was a talk on OT etiquettes and all, really very nice. Like that topics, if we have that, which we have to carry more. And this is really a good, and Madhusudan is that person, and we'll hear, he's still in OT, I think, but not in green dress, he's in blue dress. I thought for green concept, he'll come in green dress. And his HOD Sumesh will tell in the next meeting that, okay, the green concept should go in the green dress. And very good, not only I'm not telling that, Sumesh, that vaporizes and topics are really nice, that nice to hear. Unfortunately, we could not meet Sumesh in Shillong. Meenakshi and me missed him, and otherwise he would be. Okay, let us see, hear from them. Thank you. Thank you, Meenakshi, for giving this opportunity.
Thank you, Dr. Venkatagiri, sir. Now it is my duty to introduce the faculty. And first of all, I thank all the 4 faculty. And just like that, we have passed 38 weeks. So it is a big task. Every webinar, 4 speakers participated. And by 38 means we have crossed that 100 at the 25th meeting itself. And another 52. So 152 speakers participated in this webinar, and Pudukkottai is a very small branch. So with that we could achieve because of the cooperation across the country. And today we are very happy to have Dr. Gaurav. I don't know whether he is Gaurav Shaibint Satyavardhan or Satyavardhan, because Satyavardhan is, I think it is Bhishmacharya's name. So Satyavardhan. But it has been printed as Satyavardhan, and he has also given a go-ahead signal for us, I was thinking. But anyway, so Gaurav is safe. But only thing is, he is having a name Gaurav. At the same time, Bhishmacharya name is also there, Satyavardhan. So it is really, we are very happy to have him. He is a final year resident in the prestigious Kasturiba Institute, Mangalore. And he is interested in quizzes. So most of the time he succeeds in rapid fire round, as he is trained by Dr. Sumesh and Madhusudan. Necessarily he will be under rapid fire. So we welcome the youngest faculty of today, and Pudukkottai Budan feels happy to host one postgraduate compulsory in all the sessions as a budding teachers. So we welcome Dr. Gaurav in our team, Pudukkottai faculty. It is followed by, he is going to talk about Aladdin cassette vaporizer. So this is just like Aladdin's magic lamp. He is going to talk about Aladdin cassette vaporizer. At the outset, I have to accept Pudukkottai anesthetists have never seen a Aladdin cassette vaporizer. So in Pudukkottai, even the corporate hospitals or the government medical college hospital is not having Aladdin cassette vaporizer. So that youngest faculty has to throw light for the anesthesiologists in Pudukkottai as well as across the country. And I think only a select few stations will have that Aladdin cassette vaporizer. We are happy to listen to him. So that then the professor and HOD of anesthesiology, Dr. Sumesh T. Rao, is going to talk about these inhalation agents. Sir is a consultant anesthesiologist and a professor at HOD now, and he has graduated MBBS from TD Medical College, Alappe, and a DA and MD in Trivandrum. So his qualification is from Kerala, and he is working in Karnataka. Then Pudukkottai is hosting, Tamil Nadu is hosting the webinar. So a mini Bharat Mata is seen in Dr. Sumesh Rao. Sumesh Rao, more than that, sir has done that CPHA HM from D.Y. Patil University, Pune. So the D.Y. Patil Medical College itself is a very prestigious medical college. So he has done, I think Pune means he is mentioning about Pimpri Chinchwad. So he has graduated from that, and he is having 18 years of teaching experience in Mangalore as well as Sikkim. See, the Sikkim I want to mention, Dr. Madhusudan Upadhyaya was also working in Sikkim, and Dr. Sumesh Rao also working in Sikkim. That is very nice to have. See, even though India is a vast country, these people have made that so small that working in this corner and traveling up to Sikkim and working there, it is a very good thing. And Dr. Sumesh is a PG teacher, guide, and examiner. He is having a special interest in pediatric anesthesia, head and neck surgery, and the best part is he is interested in hospital accreditation and quality management. So I am interested in seeing Dr. Sumesh. I have applied for national accreditation in the government medical college. So we are doing it as a pilot project. Already we are going to spend 3 crores to make it as a NABH accredited center. And I think we will be contacting Dr. Sumesh shortly, because within 3 months we have to get it. So the pilot project is for 4 medical colleges in Tamil Nadu. So the government medical colleges are doing that. So Teni is doing that, and because of that only I am here. So we welcome Dr. Sumesh, and see Dr. Madhusudan always in a theatre dress, blue dress, talking about green OT. Dr. Venkatagiri felt that he is not in a green dress. He has mentioned the green OT, but the blue dress. So that means they are very much dedicated in the theatre work. Some people like me, we will appear to be dedicated, but we will not be dedicated really. But Dr. Madhusudan is really a dedicated teacher, and see his academic interest cannot be simply explained in 15 minutes or 5 minutes. It's very difficult. He is such a passionate reader, and he is an editor for this Karnataka journal. And now, to his credit, he has become the South Asian editor in charge for the South Asian Anesthesia magazine. So that is a great credit Dr. Madhusudan Upadhyaya got in a recent meeting in Shillong. He is a good friend, and see, he was previously he was a medical superintendent of Kasturiba Medical College. He was a professor now, but whenever you meet him, you talk with him, that authority tone will be missing. He used to say, wherever we meet in the conference, most of the time we pick up quarrel as a pro and con session. And he used to say in conference, Madhusudan is for education and Meenakshi Sundaram for entertainment. So he is pretty sure Meenakshi Sundaram cannot educate anyone. So he has made a statement, Madhusudan will be educating and Meenakshi Sundaram will be entertaining. At least what I know only I can do. He knows teaching, so he is educating. But I don't know that. So I want to entertain people. I am doing that. He's a very good friend of mine, and for the first time, I have seen his spouse also in Shillong. Both are made for each other, and for such a type one personality like Dr. Madhusudan, Madam is the correct pair to keep himself cool. She's doing everything. I wish them all the success in life. And routinely, we will be struggling hard to find out a chairperson. That we concentrate more. We want to have a good person because to govern all these three faculty. So we could get Dr. Lalit Kumar Raigar. He is from Rajasthan. So when a South team is participating, a person from North coordinating this, we want to give a national look for this webinar. Sir has served ISA for 28 years. He was the city branch president, secretary. So from 2016 to 19, from the grassroots level, he has ascended. So he was the state branch treasurer, Rajasthan, then West Zone president, and he is a president elect for the state 2022-23. He is a IJA editorial board member. He is the organizing secretary of the state conference, and he was the additional principal. Now he is for 5 years, and now he is a principal. And the obstetric anesthesia society, he was a founder member, and he has become a treasurer. He has become a vice president of AOA. So we wish Sir also to come to greater heights in ICAA in general. And with this introduction, now I hand over the academic session to Dr. Lalit Kumar Raigar, sir. Sir, please take it over. Unmute yourself. Sir Raigar, sir, you can go ahead.
Yes, sir. Yeah. Thank you very much, sir. One remark that you had mentioned that you are entertaining. Are you able to hear? Hello.
Sir, yes, sir, we are able to hear.
Yes, sir. Sir, it is not an entertainment. It's keeping all cool. So with cool minded, everyone can able to concentrate. And that is again a educative part. Thank you very much, sir. Can I invite now to our youngest speaker who will speak on the Aladdin cassettes, as Saraj mentioned, magic one. So let us listen our youngest speaker. Dr. Gaurav.
Yes, sir. Good evening, sir. Am I audible, sir?
Yeah.
Are my slides visible now?
No,
Yet.
not yet.
Slide share.
Gaurav, you have to share screen.
Yes,
Yeah.
sir.
Dr. Gaurav, what you have done earlier, you have to do.
Yes, sir. That option is not there now.
Shilpa, any issues?
Yeah, sir. No, sir, no issues.
Okay.
Now is it visible, sir?
No.
No, we can't see your screen, doctor.
No.
Or I think we can go to Dr. Sumesh.
I can do that, yes.
Yeah.
Yeah.
Because we will never wait. Yeah. That's right.
Yeah.
I
Sure.
think my slide is up.
Yeah.
Yes, sir.
Yeah.
Go for slideshow mode, sir.
Yes. Yeah, I hope my video is also on.
No, not it.
All right,
Yeah. Now, yes.
done.
Yes.
Okay, thank you very much, everyone, for helping out in this. And first of all, from Kasturba Medical College, Mangalore, and the Manipal Academy of Higher Education, I want to sincerely thank the ISA Pudukkottai branch for inviting us and honoring us with the opportunity to speak at this 39th weekly session of the academics. And again, sincere gratitude for giving us the opportunity to listen to all the speakers speaking on a variety of topics. Thank you, Lalit sir, and good to see you again. So moving on to the topic of the day, since the time allotted is only about half an hour. So what we were asked to focus on today is on inhalational anesthetics and why and how they work, and what concerns do we have when using them, and what can we do better to make our patient management safer and more efficient. So the topic that was assigned to me is the pharmacokinetics of the inhaled anesthetic gases. I will not be going very deeply into the theories of how the gases work, the microscopic, micromolecular, macromolecular, etc. Nor will I be dealing with the dry and definitely boring Mappleson's theory of distribution, flows, redistribution, etc. What we'll be focusing on in short is the questions that I usually ask at the examination for our younger friends, the residents, and we'll be trying to understand what exactly are the anesthetic gases and how can we use them better. So why did we move on from the initial, the IV agents to the gases? So gases have been around since the advent of ether and chloroform in the 1870s, but they have been commonly used only after the discovery of the fluorinated gases from the 1950s. And in another 2 or 3 decades, these became widely available around the world. So now we have safe vaporizers, safe gases, and we can use these very effectively to provide the complete gamut of anesthesia for our patients. So why gases instead of IV agents? The gases are popular for us because of their ease of administration. So basically you pump in the gas, the patient inhales it and absorbs it, and it acts on his brain and the target sites. How do you take him? So if you are giving an IV agent, you have to inject, and then you have to wait for the circulation to take it across the body and to the target organs, and you have to wait for the tissue metabolism and the excretion of the drug for the patient to recover from that. But here, provided the CVS and respiratory physiology is normal, it's as easy as the patient inhales the gas, it works on him, you stop the flow, and the patient exhales the gas and starts recovering from the gas. So nothing is as simple as that. And our modern anesthesia workstations and the vaporizers and all the monitoring we have available, including gas monitoring, has made all this very easy and safe for us. So the second feature is, of course, the ability to directly monitor the effects, including the inhaled concentration, the exhaled concentration, the MAC, and the recovery from the gases. Now, there have been several studies comparing TIVA to or balanced anesthesia to the use of anesthetic gases alone. So we all know that TIVA, the monitoring as well as all the IV drugs make the technique very expensive, even though it also is increasingly finding use in, say, day case surgery and short duration surgeries. But compared to that, studies have brought out that balanced anesthesia or anesthesia with gases could be more cost effective. And of course, the recovery period in the post anesthesia care unit is also reduced with these. So the patients recover faster, leave the hospital faster, and that is what brings down the cost. Finally, most of these gases also provide unconsciousness and analgesia. They prevent recall and provide excellent muscle relaxation as well, and a good patient safety profile. So if we take a brief peep into the history of these gases, so we know that we have been using and hearing about the anesthetic properties of gases like diethyl ether, chloroform, and nitrous oxide from the 1840s. So we started off by having our illustrious forefathers in anesthesia using first diethyl ether and then chloroform, and then trying out various gases and moving on to the fluorinated ones. So all of these have, interestingly, all of these have been given up due to various side effects, and we have discovered better drugs with better safety profiles. Nitrous oxide, interestingly, since about 100 years, it has still been around, and I don't think it will ever leave the scene completely, even though in our ORs, for example, we use it at the most only for the initial effects during induction, and then switch over to air, oxygen, and the inhalational anesthetic gas. So Dr. Madhusudan will be teaching us all about, we have to think about the future. It is thought that the earth is always already past the point of damage where, we have been harming the earth. We have been making other animals extinct, and we have been using up our natural resources, including the anesthetic gas halogen. It's no longer easily available. So that is where the importance of the green OT concept and conserving all of these gases, preventing their leakage, preventing toxicity comes into place. So as I said, all these gases have been around for about a century, but from the 1850s, it was more than 80 years before the present inhaled anesthetics were introduced. And in the 1950s, you had the advent of the fluorinated gases. But were these completely better? No, they had various systemic toxicities, as you know, especially renal and hepatic toxicity. And most of these gases at the time were flammable, and you had burns, you had explosions in the OR, with the exception of the nitrous oxide. So halothane was synthesized in 1951, and it started being clinically used in 1956. And as we know, across the country, especially in the peripheral areas, halothane is still in use. And it is actually very pleasant, effective, and cheaper compared to the other gases, provided you keep the side effects in mind and you don't overuse the gas. So all of these were, especially halothane, the arrhythmias with halothane. So due to the enhanced arrhythmias with other drugs, especially epinephrine, if you had to use it perioperatively for resuscitation or hypotension, so the scientists kept searching for new derivative gases which would be safer. So that was how enflurane got introduced in 1973, because nephrotoxicity was less likely than the other gases. It did not have the comparable dysrhythmic effect, but however, it was thought to have epileptogenic potential. We then moved on to the safer gases like isoflurane, sevoflurane, etc. Isoflurane was introduced in 1981, and sevoflurane came into use in the 90s, and it has spread across the world. Now, from 2000 or 2010 onwards, we have had it across India, and we have been using it extensively. So it looks like sevoflurane is here to stay, and it gives the complete and pleasant anesthetic profile for us as well as our patients. So we should also know that these gases are very costly to develop for the companies. So they have more or less stopped research into newer gases because, one, it is very costly. Two, we have already reached the safety profile where using all of these is pleasant, safe, and effective. So further research may not be, very productive for them. So be that as it may, we also had the new gas desflurane, which was the last one to be introduced in 1993. So we do have desflurane vaporizers in our OR, but then the cost is 3 to 4 times that of sevoflurane, which itself is about 1.8 times as costly as isoflurane. So that's where we are. Desflurane has specific uses and indications, and as you know, it is not used much because of the cost. All these gases have a low blood gas solubility, but however, they seem to work better even in terms of nitrous oxide because of their properties, which we will see in the talk today. All of them provide rapid induction and rapid recovery and precise control of the anesthetic concentration with our modern workstations and monitors. So just looking at the list of all the inhalational agents, the volatile anesthetics were diethyl ether, where we started, divinyl ether, which was given up because of cardiac toxicity, ethyl chloride, which is still in use only as a spray for topical anesthesia. Chloroform is still available, but not in anesthetic use. Praline has been given up because of the complications. Halothane is still around. So the ones that I have marked in red here are the ones that we are still using in India. So if we keep the hepatotoxicity, the idiosyncrasy, etc. in mind, it is still a gas that is pleasant and I would not mind using. Methoxyfluorine is out because of the nephrotoxicity, and fluorine is out because of probably the nephrotoxicity and the anti-epileptic effect we mentioned. So the gases that we use now among the fluorinated ones are isoflurane, thioflurane, and maybe desflurane in that order. And on this side, the non-fluorinated drugs, we have nitrous oxide, which, as I said, it will always be around, but we should be cautious with using it because of the side effects as well as trying to limit its use. Cyclopropane is out, ethylene is out because of the explosive nature. Xenon is increasingly getting rarer along with halogen, but it is, especially in Japan, they have been using it both for anesthesia as well as for ventilation. Argon could be another gas that could be used with a similar profile. Interestingly, historically, there is a mention of sulfur hexafluoride as one of the anesthetic gases that we have tried in history, and it also provides mild analgesia. Anyways, these are all only for historical importance. So if we look at anesthetic gases, how do these get transferred and how do they work on the body? So the effective target site is the brain, where we need to get the anesthetic gas from the cylinders or the pipelines through the anesthesia workstation while monitoring the patient, monitoring the uptake by measuring the FI, monitoring the output by measuring the end-tidal concentrations. So the fresh gas flow into which the gases are either injected or diffused across the breathing circuit and the airway management devices, the gases reach the lungs. So we will see that it is all an interplay of the concentration in the lung and the alveoli, the uptake of the gases from the alveoli across the concentration or diffusion gradient or active diffusion to the pulmonary vasculature, and the efficacy of the heart, which pumps to get the blood to the brain and to the other target organs where the gases do their magic. So we all know that fresh gas flow is what we set, and it is determined by the vaporizer and the flow meter settings that we put into the machine and calculate. So the important things that we should focus on for understanding how the gases work would be the FI, which is the inspired gas concentration, which is determined by our fresh gas flow, the efficacy of the patient's breathing and the breathing circuit volume and circuit absorption, which is a minor factor, but one that we should keep in mind. There is then the FA, or the alveolar gas concentration. So it is all, as I said, the uptake is an interplay between the FA and the FI. So it depends on the FI-FA ratio, and the FA itself is determined by the uptake, which you can see the formula there, the ventilation or the efficacy of getting the gas to fill the alveoli, and the concentration effect, the pumping effect, the second gas effect, etc., which is something that we can do with the vaporizers. And lastly, F, so that was F capital A in the alveoli. And then we have F small a, as we know, just as for the partial pressures. So you could also say that these are maybe proportional to the partial pressures in each fraction. So the F small a is the arterial gas concentration, which is affected by the ventilation perfusion ratio and the uptake as well as the efficacy of the gas. The recovery from it would be affected by shunting or ventilation perfusion mismatch, which hopefully our ASA 1 and 2 patients will not have. So that's what we depend on. The focus or the thrust of the talk today was supposed to be on pharmacokinetics. So we know that pharmacokinetics is what the body does to the drug, and pharmacodynamics, we have been taught, is what the drug does to the body. So in this talk, we are looking at pharmacokinetics, which is all about the administration of the drug, the absorption of the drug and the distribution, and the final clearance and concentration. So what exactly is the pharmacokinetics of inhalational gases, as we should understand? So we have already said that the critical and clinical effect of these gases depend on them reaching the brain first of all, and then attaining a therapeutic tissue concentration in the CNS, and stabilizing or reducing the excitatory potentials across the neurons and axons in the brain. So the effect site concentrations of the gases is what is important. This is related to the partial pressures of these agents in the CNS and the other fractions, the vascular and the alveolar fractions. So you can say that ultimately our aim is to equilibrate the alveolar concentration, which is the inhaled concentration, with that in the CNS. So our uptake and release of the gases, it depends completely on the alveolar concentration of the anesthetic agent, one. And second, the uptake from the alveoli by the pulmonary circulation, and then reaching these across the blood to the brain. So if we look at the uptake and the distribution of gases, so we know that mechanically the liquid anesthetic is pressurized and vaporized in the vaporizers. It is mixed with oxygen and maybe nitrous oxide or air, diluted with air in the fresh gas flow. The FGF mixture is then delivered to the patient via a face mask for small procedures where you can hold a mask and mask ventilate, or with any of the airway management devices that you're putting in and connecting to the anesthetic circuit. So the gas mixture then travels to the lungs, or to be more correct, more anatomically exact, you would call it the alveoli, up to the terminal alveoli, and then across the alveolar pulmonary circulation interface, the gases diffuse across the active concentration gradient depending on their solubility, and then they are carried through the bloodstream, again depending on solubility and the concentration. Ultimately, within seconds to minutes, depending on the circulation, they reach the brain and produce their effects. So the diffusion rate of the gases is what is important here, and this itself is dependent on the concentration gradient across the alveolo-capillary interface. That is one. And the second thing you should keep in mind is the lipid solubility of the individual anesthetic gases. And as you know, the concentration gradient is greatest during initial induction. So if you look at this time, the alveoli right now is filled with atmospheric air, which is what the patient is breathing. If you have been effectively re-oxygenating, or more correctly denitrogenating, then you would have replaced the atmospheric air with, we are hoping that more oxygen gets in there and gives us more time for safely inducing the patient. So once we start pumping in the anesthetic gas, so across the concentration gradient, the oxygen gets absorbed, some of the anesthetic gases get absorbed, and then the gases fill the alveoli, producing the increase in concentration. And then across the concentration gradient, it diffuses into the pulmonary vasculature, then into the systemic vasculature, and then reaches the ultimate target site, which is the brain. So what factors would affect the uptake and release of the inhalational anesthetic agents? So we are interested to know these, just like for all the other drugs. So the main factors we said are the alveolar concentration of the inhalational agents and the drug uptake from the lungs. So the concentration itself, or the FA, will depend on the inspired concentration which we are providing, that is the FI, which itself is controlled by the fresh gas flow or the dilution of the gases, the volume of the breathing systems, and minimally by the circuit absorption, which means that some of these gases might get absorbed into the plastic or rubber material of the circuit, which we want to minimize or keep it small so that it does not affect the concentration reaching the alveoli. The next factor is the efficacy of the alveolar ventilation. So alveoli should be opening and closing properly. There should not be a fluid interface in between, and the gases should be able to diffuse across the thin alveolar surface to the pulmonary vasculature and to the systemic vasculature. Functional residual capacity, or the amount of gas, residual gas remaining in the lungs after a full expiration, also is an important factor, because if the FRC is more, you would have dilution of the gas that you are pumping in. So the effective alveolar concentration would be less, and vice versa. But remember that if the FRC is reduced, as in say an obese patient, or even somebody who you lay supine for the GA, or a pregnant lady, then it would give you a less window of opportunity for a safe induction, be it with anesthetic gas or with IV agent. Now, coming to the second factor, which is the drug uptake from the lungs. So this is all a physical property of the solubility of the gases into, say, the lipid and the blood. And the carrier, the solubility in the blood is also important, because the blood and the cells in the blood into which the gases diffuse or get absorbed are what carries the gas effectively to the brain. So we need to know the blood gas partition coefficient and the oil gas partition coefficient, or the solubility in lipid. The second factor is the pulmonary alveolar blood flow and the cardiac output, which should be efficient and which should be adequate for the patient without any shunting. The third important thing is the alveolar to venous partial pressure gradient. And finally, we have the artifacts that we can produce to make the mechanism more faster, knowingly or unknowingly. So these would be the concentration effect, the second gas effect, and the pumping effect. We look at all of these. So the alveolar concentration, as we mentioned, it depends on the inspired concentration of the agent, which ultimately is the concentration or the fraction between the alveolar fraction and the inhaled fraction. So we are aiming to keep the FA-FI ratio large. So when we increase the inspired gas concentration, that is the FI, it also has the effect of increasing this proportion and thus making the induction with the gas faster. So which is why we dial up the sevoflurane to the highest on the vaporizer when we are trying to do a volatile induction with sevoflurane. The second factor is the alveolar ventilation, or the amount of the fresh gas that is along with the anesthetic gas that is reaching the alveoli up to the terminal alveoli. We have also already mentioned the role of the functional residual capacity and how it affects the efficacy of the anesthetic agent. The drug uptake, we said, depends on the lipid solubility and the blood gas partition coefficient, the cardiac output, and the pulmonary alveolar blood flow. Remember that you don't want shunting. And finally, the alveolar to venous partial pressure gradient and the uptake. We will also look at the effect of specific factors like obesity and age on blood gas solubility and anesthetic uptake. So you know that the extremes of age, either children or elderly, so their circulation is less effective. So even though the solubility might be there, the transport factor gets affected. So induction as well as recovery might be slower at the extremes of age. Obesity, so there is also the vessel width group, there is the fat into which the gases also get absorbed or diffused, and that might also affect the induction with the gas. So what are the characteristics of all these gases which govern the anesthesia or make them useful for us? So this is the partial pressure of the anesthetic in the inspired gas, the FI that I mentioned, which we can control by our ventilator and machine settings and the vaporizer setting, and the fresh gas flow. The pulmonary ventilation, which is the fraction reaching the alveoli, the exchange in the alveoli between the alveolar chamber and the pulmonary vasculature, the solubility in the blood, which is governed by the blood gas partition coefficient, and the solubility in the fat, which is governed by the oil gas partition coefficient. So why are these physical and chemical properties of the gases important to us? We have to consider, so for using these effectively and for getting the anesthetic effect, we need to keep in mind the vapor pressure of each of the gases that we are using in the individual vaporizers. the partition coefficient of the gas in the body, the alveoli and across the vascular interface, the minimum alveolar concentration of each gas, which is effective in suppressing stimuli, and at the end in the patient recovery when you look at MAC-awake. And finally, as I mentioned, the solubility into the circuit, that is either the rubber or the plastic which constitutes the circuit. When we look at each of these, the vapor pressure, so each of these questions for the residents, it could figure in your viva or it could be short notes. So please do read up on all of these, including the Mapilson's theories of distributions, the various flows and the fractions. And you might also read up on the things I mentioned, like the concentration effect, the second gas effect, the pumping effect, etc., which I look at briefly at the end of the talk. So coming to the vapor pressure, this is the amount of pressure exerted by the gaseous form of any substance when it is in equilibrium. So what we should underline here is when in equilibrium. That means that there is no uptake or there is no net excretion of the gas from the body, which means that the absorption from the fresh gas which we pump in, the utilization in the body and the excretion in the exhaled gas is at equilibrium, and the net input needed at that time is 0. So this vapor pressure is governed by the ability of each gas to evaporate. So basically the boiling point has to be lower. So the gases which have a lower boiling point would be expected to reach the gaseous state more easily, would be expected to act faster, and the patient would also be expected to recover faster when you are stopping that gas. So the vapor pressure is the property that determines how readily the inhalational anesthetic agent would evaporate in the plenum type of anesthetic machine vaporizer. And this property is also dependent upon the physical environmental factors, that is the temperature and the particular anesthetic agent that you are used. You have heard about heated vaporizers providing the vaporizer itself gets cooled, that again. So this all something that can be discussed in only a long talk. So you should read up on the effects of temperature on the vaporization, as well as the provision of heat to counteract the cooling and reduced effectiveness of the vaporizers. Moving on to the second physical factor, which is the blood gas partition coefficient. So the BGPC as well as the oil gas partition coefficient, or the solubility, is what mainly controls the efficacy of each individual anesthetic gas to be safe and to be effective in anesthesia. So coming to the blood gas coefficient, it is the measure of the solubility of an inhaled anesthetic in blood as compared to the alveolar gas. So the BGPC value would be an indication of the speed of induction and recovery from an inhalational anesthetic agent. And a low blood gas partition coefficient would mean that the agent is more soluble in the alveolar gas than in blood at equilibrium. So it is more easily in the gaseous state than the dissolved one. So which means that it can be pumped in more easily to reach a large alveolar concentration. And at the end, when we stop the gas and the concentration drops, the patient would be expected to recover more easily, since the agent is less soluble in blood. So the effect that we get and we want is a faster expected induction and recovery from the anesthetic, which shortens the hospital stay, which also shortens the cost to the patient. So the BGPC is a measure of solubility in the blood, which determines the rate of induction and recovery of inhalational anesthetics. So the lower the blood gas partition coefficient, the faster the induction and recovery. An example to this would be the gas nitrous oxide, which is why it is still a favorite with all of us, along with its analgesic and amnesic properties. The higher the blood gas coefficient, the slower the induction and recovery from the gas would be expected, which is, among all these gases, when you compare, halothane would have a higher value. So looking at all of these, so what we have been talking about is the efficacy or how the gas works. So these are a function between the alveolar concentration, the blood compartment concentration and the concentration at the ultimate target tissue, that is the brain. So if the blood gas partition coefficient is lower, as in the gas nitrous oxide, then you expect that induction as well as recovery would be much faster. If it is slower, as in halothane, then the rate of induction as well as the recovery would be expected to be slower. So how does this work? So we said that blood gas partition coefficient is directly proportional to solubility. So this is just like, pouring sand into a bucket. It is not soluble. So if it is less soluble in blood, the blood gets quickly saturated with the anesthetic gas, and the additional anesthetic molecules are then readily transferred to the brain. So that is how nitrous oxide works, because it is about 30 times as soluble as nitrogen and much more soluble than the alveolar air that we breathe in. So it is readily transferred to the brain. And at the end of the procedure, when you stop the nitrous oxide, it again readily diffuses out of the blood back into the alveolar gas and is exhaled out by the patient, which is how he also recovers very fast from the nitrous oxide. So this is compared to the gas with a higher blood gas coefficient value like halothane, which gets dissolved more in the blood. So from the alveolar fraction, you see that the gas is mostly dissolved into the blood, and it reaches the brain much more slowly, and the ultimate efficacy would be slower. The recovery also would be less pleasant and slower than from gases like nitrous oxide, which are readily diffusible. The next property is the lipid solubility, or the oil gas partition coefficient. So this correlates strongly with the potency of the anesthetic. So what do we mean by potency? Maybe loosely I can call it efficacy. It is how effective each drug is on the body or the target tissue to produce its intended pharmacological effect. So the BGPC means how fast the gas reaches the brain, but the lipid solubility or the oil gas partition coefficient means how exactly the gas interacts with the brain, or how much effective it is on actually producing the anesthetic effect in the brain. So the higher the lipid solubility, the more potent the anesthetic gas would be. So which is where halothane is. Again, it has a high oil gas partition coefficient. So we said that it gets there slower, but then it acts faster, or it acts more on the brain because of the lipid solubility. So it's all a balance of the efficacy and the properties of the gas. So this would be a graph showing the importance of the oil gas partition coefficient. So you have nitrous oxide, which has a low value of the oil gas partition coefficient. At the other end, you have halothane, which has a very high OGPC. So how exactly does this translate into effect? You can see that halothane at this end has a very low MAC value as compared to nitrous oxide, which requires about 100%. That means that you have to replace all the oxygen in the alveoli with nitrous oxide, which certainly is not a safe thing to do. So the more the oil gas partition coefficient, the less the MAC value of the gas. So what is this MAC that we have been talking about? So the Mayer-Overton theory, again, which is something that you should all be reading. So the minimum alveolar concentration of any gas has been defined as at steady state. So this is all at equilibrium when intake and output are equal, and you don't have to put in. So it has equilibrated across the body and the vascular compartments and the brain. So you don't have to put in any more gas to produce the anesthetic effect at this ideal state. So which might not be reached always because of various factors. So the MAC is the expired gas concentration of the anesthetic, which you are measuring on the monitor at 1 atmosphere of pressure. I have already mentioned at equilibrium that prevents movement in the patient in response to a noxious or painful or surgical stimulus in at least 50% of the patients. So we can say that the MAC value would be loosely analogous to the ED50, which is the effective dose 50, which again is the effect of the gas where it produces movement in response to it inhibits movement in response to surgical stimulus in at least 50% of the anesthetized patients. But the difference between MAC and ED50 would be MAC is the efficacy, while ED50 is the best measure of the anesthetic potency, as that mirrors the pressure at the brain interface and the effect of the gas at the brain. So suppose you use or add different anesthetic gases into your fresh gas flow. For example, nitrous oxide, oxygen, and an inhaled anesthetic agent. The MAC values of the different anesthetic gases would be roughly additive. Now, what is the importance of MAC? Does it actually translate to consciousness as we try to measure it? Actually, the MAC inhalation value would probably not be an accurate measure of the consciousness. We would get that more for the MAC awake at the end of the procedure, when you are withdrawing the gas and allowing the patient to recover from the gas by exhalation. And the MAC awake would be the time at which 50% of the patients would respond to a verbal stimulus. So that probably is thought to be a clearer marker of consciousness than the MAC at induction. So we might not be able to depend only on this one factor for thinking that our patient has reached the plane of anesthesia. So we said that the MAC value is a measure of the efficacy of the inhalational gas, and we already mentioned the definition of the MAC value. We said that the MAC values are additive when multiple gases are mixed together in the fresh gas flow. We should also remember that the MAC values are reduced in the presence of IV anesthetic agents as well as the opioids, which also produce a depressant effects on the brain. So the safer MAC values to be used during surgery to reach a surgical plane of anesthesia, it's supposed to be about 1.1 to 1.2%. So we have different measures for the minimum alveolar concentration values. You have heard of MAC bar, which is the MAC that blunts adrenergic response or catecholamine release to noxious stimuli. This is attained at about 1.5 of MAC. There is the MAC unconscious, which is the MAC at which the patient starts losing consciousness. So that starts at about 0.4 to 0.5 MAC when you're using PMA. And I have already mentioned the MAC awake, which is at the end of the procedure when you're allowing the patient to recover from the gas. And this is the MAC at which the patient opens his or her eyes to command, which again is reached at an end-tidal or exhalational MAC value of 0.5 to 0.15. So what is the effect actually of MAC, and what is the safety or efficacy of increasing the MAC values? So this is based on, so you can see the down arrow here and the increasing concentrations of the MAC fraction. So at MAC 0, the patient would of course be awake. At 0.3, it might be the stage of excitement. You see that when you're using only inhaled gases, balanced anesthesia has made this stage more or less disappear by the speed and efficacy of the technique. At a MAC of about 0.6, you have the MAC unconscious, which is loss of consciousness. And at 1 MAC to 1.3 MAC, you would have loss of movement to noxious stimulation and less catecholamine response to the surgical stress and the pain of the incision, which is what you want. If you exceed this value of about 1.3 MAC, you start getting the deleterious effects of the gases, which is hemodynamic depression. At 1.5, it also moves into ventilatory depression by affecting the respiratory centers in the brain. And the higher up you go from there, the more your side effects and the hemodynamic effects. And at a MAC that exceeds about 2.5, you would have permanent damage or death in the anesthetized patients. So if we look at the MAC of each of the inhalational agent, for nitrous oxide, we already mentioned that we need more than 100% to provide effective analgesia and anesthesia by itself. The MAC value here is 104. For halothane, it is the least among the other gases. It is 0.75. Isoflurane has a value of 1.17. Ceoflurane 1.8, and desflurane has 6.6. So remember that roughly 1.3 MAC of any of the above volatile anesthetics can provide the ED50 as well as the MAC value that prevents movement in about 95% of the patients during the surgical stimuli. So what are the factors that affect the minimum alveolar concentration? You have factors that increase the MAC and increase the efficacy, or you also have factors that, decrease the efficacy, and you have the factors that decrease the minimum alveolar concentration, thus giving you faster inhalational induction as well as recovery from the gas. So if we look at the factors that increase the MAC, so increased CNS metabolism would mean more excitatory and stimulatory neurotransmitters. To suppress them, you need more of the gas. Again, increased neurotransmission in the brain, which is contributed to by hyperthermia or a raised ambient temperature. Chronic alcohol abuse stimulates a lot of the metabolic enzymes, as well as habituates the brain and other CNS tissues to damage to the inhibitory effects of the alcohol. So this translates to needing more of other IV agents like opioids, as well as needing more of gases to reach unconsciousness and the surgical plane. Hyponatremia would also increase the MAC, and drugs like the monoamine oxidase inhibitors, sertraline, fluoxetine, etc., can increase MAC. Amphetamine again is a stimulant and increases the value. Cocaine, is a potent vasoconstrictor as well as a very effective or strong CNS stimulant. Ephedrine is again a vasopressor as well as CNS stimulant. And L-dopa, of course, is a direct neurotransmitter. And all of these factors increase the MAC value. The ones that decrease the MAC value, meaning these are patients that have other factors in play. They may be your ASA 3 or 4 patients. They may be patients at extremes of age and other factors which increase morbidity. So you have to keep in mind the safety profile of the gas. You have to keep in mind that induction may be faster at reduced doses, but recovery may be delayed and the patient may need postoperative care, monitoring, and even ventilation. So the factors that decrease the MAC values are a reduced CNS metabolism and reduced CNS neurotransmission due to direct or indirect CNS injury. It can be attenuated by hypothermia, which might be iatrogenic or might be due to environmental factors. I have already mentioned the extremes of age, pregnancy, and obesity to be factors that decrease the MAC. Alcohol intoxication again can do that. Hypotension would mean the circulation is less effective. So while it takes longer for the gas to reach the brain, it also takes longer for the recovery of the brain from the gas at the end of the procedure. Hypoxemia, of course, leads to cerebral and pulmonary vasoconstriction at the end, and that might affect the MAC value adversely. Narcotics, ketamine, benzodiazepines, and other IV agents also have a synergistic or additive effect, and they reduce the MAC of gases if you're using them together. The factors that are supposed to have no effects on the MAC are gender, the duration of anesthesia. I mean, we use more of gases and we use more of short-acting, non-depolarizing muscle relaxants. We see that the recovery with propofol, balanced anesthesia, and short-acting NMBs is much better now, and the patients are coming around faster, even though the duration of surgeries are increasing, and we have more and more morbid and aged patients. Hypertension is supposed to have no effects on the MAC. It is more the circulation or the dynamics of the blood flow that affect the MAC. Anemia, while increasing the circulation, it may lead to a hyperdynamic state, but again, it is reducing the number of cells and the solubility of gas in the blood. So those effects balance each other. Thyroid status again is not supposed to affect the MAC. Hypo or hypercarbia, while the oxygen level does affect it, carbon dioxide is not supposed to. Metabolic alkalosis, hyperkalemia, and magnesium levels, which are nutritional as well as metabolic factors, might not have an effect on the MAC value. So when we look at all of these gases and put them all together, we have discussed why gases and how do we use them, how do they work, how do we manipulate the effect on the gas of the gas and the potency on the brain. We have looked at the history of the various anesthetic gases and how we came to selecting and using the gases that we do right now. And are they a viable alternative for the IV agents? Because you can keep down the cost, you can make the recovery faster and more pleasant. You can also make induction safer for the patient. So we have looked at the physical properties of the gases which affect the efficacy. Those are the blood gas partition coefficient and the oil gas partition coefficient. So looking at the values, nitrous oxide requires more than 100 for its MAC, and BGPC would be around 1.4. Then at the other extreme, you have halothane with 0.8 and 220. And you have the gases that we use routinely now, isoflurane and sevoflurane, which lie in between nitrous oxide and halothane. And you also have desflurane, which is pleasant, which gives a very safe and rapid induction, which diffuses in and out rapidly and does not metabolize in the body at all. So that might perhaps be the ideal gas for anesthetic use if it were not for the cost, which is the most overarching factor that affects us in India. So I said that I would also look briefly at the effects of the gases, like the concentration effect, the second gas effect, etc. So what is the concentration effect? This is just a function of the pressures and flows that you set at the vaporizer. So at the start of induction of general anesthesia, when you are starting to pump nitrous oxide into the alveoli and into the pulmonary capillary blood, it overwhelms all the other gases actually because of its solubility and rapid diffusion, which is 30 times that of the nitrogen in the atmospheric air, which is about 200 times that of oxygen itself. So it rapidly replaces all the other gases in the blood. So the alveolar fraction itself shrinks and the volume of the alveoli shrink. So this means that because all the N2O is now in the pulmonary capillary blood as rapidly as possible, so the concentration of the other anesthetic gases remaining in the alveoli is increased, which means that the more the absorption of the nitrous oxide, the more the efficacy of the other gases, just because the proportion of the concentration is increased in the FA, that is the alveolar fraction. So that's what we are looking at here. So there is the concentration effect, which might either be due to the concentrating effect of the nitrous oxide itself or increasing the flows, or it could be an augmented gas inflow in which other gases are added and diffused rapidly along with the nitrous oxide. So this could be a short note for the residents in the final examination. So the concentration effect is also called over pressurization. So where what we do is give a higher inhaled concentration or FI of the gas, so the FA rises quickly. So this is just like the IV gases, IV agents, where we give boluses to rapidly produce a effective or therapeutic plasma concentration. So here we are increasing the dose to increase the alveolar fraction and the inhaled fraction of the gas. So this exactly is why the FA by FI ratio rises immediately for nitrous oxide, because higher concentrations are used than other gases like desflurane, even though it is less soluble. So when you look at the diagram here, so that's the concentrating effect that is shown. So when you increase the flows of or the FI by 5 times, so it is not linear, it is actually multiplied. The concentration effect is multiplied, and a 5 times increase in the FI yields about a 6.2 times increase in the FA, because the other gases remaining, so alveolar volume itself shrinks after the nitrous oxide rapidly diffuses out, and the concentration of the other gases in the remaining proportion is much higher now. So moving to the second gas effect, again, this is because nitrous oxide rapidly diffuses, but it is very insoluble in the blood and other tissues. So this results in rapid flows, rapid diffusion, and rapid equilibration across the alveolar and the pulmonary fraction and the fraction in the brain. So the rapid uptake of nitrous oxide from the alveolar gas, it serves as a carrier for co-transport. So it also helps to concentrate the other administered anesthetics, which is what we just saw. And this second gas effect, when you are adding another inhalational anesthetic on top of the nitrous oxide, speeds the induction of anesthesia by both of these anesthetic gases working together and getting transported together by the prolific and rapid diffusion of nitrous oxide. So diffusion hypoxia at the end of the procedure, when you are allowing the patient to recover by cutting off all the anesthetic gases and administering only oxygen, is actually a function of the rapid diffusion or the concentration effect. So this means that when you discontinue the nitrous oxide administration, again the concentration in the FA fraction is falling to near zero if you are replacing it with oxygen. So the nitrous oxide gas can rapidly diffuse from the blood to the alveoli, diluting the oxygen in the lung, which is getting absorbed. So if we are not giving 100% oxygen for some time over this recovery period, then all the nitrous oxide that diffuses out and replacing the oxygen in the alveoli means that you can have a hypoxemic state in the patient if we are not careful. So this produces the effect that is called the diffusion hypoxia, or named the Fink effect after its discoverer. So this is just because of the rapid oxygen dilution in the alveoli by nitrous oxide, which is replacing it, and the subsequent hypoxia. So you need to keep in mind that 100% oxygen administration for at least 3 to 5 minutes should follow the cessation of nitrous oxide at the end of the procedure. So this is just a table that puts together all the properties of all the anesthetic gases. So you know that all of these have been used for gas induction. So halothane was very pleasant, along with the other gases like sevoflurane and nitrous oxide, which are used for induction. Enflurane was given up because of the excitogenic effect, the renal toxicity, and the pungency. Isoflurane again is in use for maintaining anesthesia as well as maintaining the hemodynamic profile, the circulatory fractions, but then it is pungent and it cannot be used by itself for volatile induction. So sevoflurane, nitrous oxide, and halothane are the gases that you can use for induction. Isoflurane you can use for maintenance during the anesthesia. If you have desflurane, again remember that it is irritant, not as pleasant as the other gases at induction, and it can lead to secretions. So it again provides a profile where you've got a safe and effective induction as well as rapid recovery from the gas. So the side effects of these gases would be halothane. You should keep in mind the arrhythmias, the hepatitis, idiosyncrasy, hyperthermia, anaphylaxis, etc. Enfluranes produces seizures as well as hyperthermia. So if there is a population in which you have chance of malignant hyperpyrexia, these are all the fluorinated agents are all ones that you want to avoid. And isoflurane, as I said, it is widely used. Sevoflurane is supposed to be pleasant and efficacious, but then we are worried about the compounds A to E. We are also worried about nephrotoxicity when we use it for a long time in a closed circuit at higher concentrations. Desflurane is irritant and can produce cough and secretions. So nitrous oxide, while pleasant, has various adverse effects if it is used for a long term. It can produce, as we saw, diffusion, hypoxia, etc. It also, so that is what Dr. Madhusudan will be talking about, safe use of all the anesthetic drugs and the minimal use of them to prevent waste. Nitrous oxide is a gas that needs a very high flow and diffuses out very rapidly, and it produces the highest environmental waste and toxicity. And it definitely, if you don't have an effective scavenging system, it will produce side effects in everyone working in the OR, including the patient, which is what we do not want. You also know that it can produce megaloblastic anemia by affecting the cyanocobalamin pathway. So what we briefly saw in the past half hour to 45 minutes was the properties of volatile gases on the body and what the body does to the anesthetic gases. So these are all the sources that I borrowed from, and I am grateful to all our predecessors, the scientists that bravely discovered as well as started using the various gases, brought out the harmful as well as useful properties, and we are standing on the shoulders of giants. So they have brought us at the end to where we can effectively and safely control pleasant anesthesia, which is cheaper for the patient, which produces rapid recovery just by the use of gases that we can introduce into the inhalation, and the patient can recover immediately when the gas is stopped by exhaling the gas. As simple as that. So pharmacodynamics is another talk altogether. So we have been looking at the kinetics. Thank you all for your patient hearing, and we can take questions at the end, as has been mentioned. You can also use the chat box for any doubts or questions. Thank you once again. And I'm greatly honored and grateful to ISA Pudukkottai branch for giving me the opportunity. Thank you and a good day.
Thank you. Thank you very much, sir. Sumesh sir. Nice lucid talk. And as sir has mentioned, we will take the question answer after completion of all 3 lectures. Now may I call Gaurav if he is ready?
Yes, sir, I'm ready, sir. 1 minute,
Yeah.
sir.
Please share your screen.
Yes. Am I audible, sir?
Yeah, audible
Yes,
as well.
we can hear you and see the slide.
Please go ahead. Dr. Gaurav?
Hello. Hello.
Yeah, please go ahead.
Yes. Good evening, everyone. Sorry for the delay. I thank ISA Pudukkottai for having me in this webinar among eminent speakers who are my great teachers. So pitching into the topic straight. So my topic is Aladdin cassette vaporizer. So what is it? It is an electronically controlled plenum type variable bypass vaporizer. So in the start of this talk, this classification, the like Aladdin cassette vaporizer to be classified into plenum type variable bypass vaporizer will be would be thought more apt. But as the discussion goes, it might change. So this Aladdin cassette vaporizer uses the concept of gas flow and vapor concentration. This vaporizer is used in Datex Omida S5 ADU and GE ASIS anesthesia workstation. The vaporizer system consists of an electronic vapor control unit, which is the main, like you can say, the brain of the vaporizer within the anesthesia workstation. And each of the cassettes are coded specifically for the inhalational agents, as we all know by the standard colors. The cassettes are colored and magnetically coded. These magnetically coded cannot be seen, but these are actually important because these cassette vaporizers have sensors so that it detects that the exact the right cassette is inserted into the right workstation. And these cassettes are designed to deliver 5 different inhalational anesthetics, namely halothane, isoflurane, enflurane, sevoflurane, and desflurane. As we all know, for each of these vaporizers, these inhalational agents, we have specific color codes, like halothane as red, isoflurane is purple, enflurane is orange, sevo as yellow, and desflurane to be purple or violet. So in this picture, you can see isoflurane Aladdin cassette vaporizer, in which you can see the eject handle, which is used for easy carrying and easy portability of the vaporizer. You can see on the rare side of the vaporizer, agent chamber, which is of a capacity of 250 cc or 250 ml of liquid anesthetic. And then you can see key filling system and liquid level indicator, which indicates whether the anesthetic agent is low or high in the specific vaporizer. So coming to the structural and functional component, the Aladdin cassette comprises mainly of 2. the agent-specific vaporizer chamber, and the central processing unit, which is integrated into an anesthesia machine. The front portion, as we all saw, as an agent-specific filling system, a glass window to display the level of the anesthetic liquid, and a handle with a lever for locking the cassette into a slot provided in the machine. This portion also houses the contact for electronic temperature sensor and liquid anesthetic agent level. So this picture is the basic for the entire talk. So this is a schematic diagram of a Datex Omida Aladdin cassette vaporizer, in which you can see that there is an inflow tract, an outlet tract, and there is a bypass chamber with a vaporizing chamber, which contains this vaporizing chamber is a Aladdin cassette, which contains the liquid anesthetic. And you can see the CPU, that is the brain of the cassette vaporizer. The most important are the dotted lines which connects the concentration control dial, the P that is present that is stated in the anesthesia chamber as the pressure sensor within the cassette chamber. And the word T, which you can see, is the temperature sensor within the cassette Aladdin cassette chamber or the vaporizing chamber. And you can see like FBC and FBC, which are nothing but the flow meters that are present in the BC stands for the bypass chamber, and the VC stands for the vaporizing chamber, and there is a fixed restrictor. So all these relay inputs to the CPU, and the only output from the CPU is the flow control valve. This flow control valve actually directs the vapor from the vaporizing chamber into the bypass chamber, which contains predominantly of the fresh gas flow into the common outlet and then to the patient. So there are three types of Aladdin 2 cassette filler systems. The enfluorine and isofluorine use a color-coded EC fill mechanism. The sevofluorine cassettes are available in a color-coded fashion, and it is of two types, EC fill or a quick fill mechanism. On the other hand, desfluorine cassettes have a filling mechanism that is compatible with safety fill desfluorine bottles. These cassettes can, as I told earlier, it has a capacity of 250 cc of liquid anesthetic. The larger rare section of the cassette is the vaporizing chamber, which contains the liquid at the saturated vapor concentration. The cassette is specifically designed liquid sump that requires a main power supply or a battery backup. So this can be a disadvantage when there is a power shortage. There can be inhibition of this vaporizing chamber and inadequate supply of these vapors to the desired concentration, and there is an adequate oxygen and air pressure at work. It is filled with a synthetic material soaked in liquid anesthetic that is arranged as lamellae with metal plates interspersed between the lamellae. They are so arranged to form a convoluted pathway so whenever there is convolution, there is increased surface area, and whenever the surface area increases, there is evaporation. So the vaporization and the efficacy of the vaporizer is maximized. The back panel has an inflow valve and an outflow valve, which are spring-loaded mechanical ball valve to prevent agent leak during transport. So this picture is, shows desfluorine Aladdin cassette vaporizer. So you can see in the diagram in the picture that it is the front panel of the desfluorine Aladdin cassette vaporizer, which shows a safety fill mechanism compatible with desfluorine bottles. And the picture on the right side, which is B, shows the rare panel with inflow and outflow spring-loaded mechanical valve. So coming to the function of the cassette vaporizer. So these cassette vaporizers are concentration calibrated. They are flow over and electronically thermocompensated that works both as variable bypass and measured flow vaporizer. So initially we saw that these are initially or conventionally. So what do convention mean? It means that it works in an ambient OR temperature and at sea level. So the atmospheric pressure is also ambient. So now we are saying that it it works both as a variable bypass as well as a measured flow vaporizer. So more specifically, it acts as an injector vaporizer, more like a diva. So what is the function? So function, how does it function as a variable bypass vaporizer? So the Aladdin cassette vaporizer is in many ways similar to other variable bypass vaporizers such as Tech 4, Tech 5, and Tech 7 vaporizers. However, there are several differences noted. So the first thing is the vaporizer as a bypass chamber, which houses a back pressure regulator that is present in the input, and it is necessary to drive the gas through the cassette. And it also has a detachable cassette that serves as the vaporizing chamber. These two separate part has to function together to form a functioning vaporizer. The liquid anesthetic is filled in the front section, as you have already seen, and enters through the rear section through the one-way valve into the vaporizing chamber. The fresh gas flow and the vaporizer output are electronically controlled with the necessary hardware and software built into the vaporizer machine, namely the CPU, the central processing unit. So this diagram shows is a schematic illustration explaining the components and the basic functional aspect of Aladdin 2, which is more modernized than Aladdin cassette vaporizer. So in Aladdin 2, you can see that there is an internal temperature sensing symbol that senses the temperature within the vaporizing chamber, and hence the cassette temperature. And also it also has a locking lever. So here the added on feature is that it also has a scavenging mechanism which is connected through a which can be seen as blue lines, and it has a cassette pressure sensor with a cassette pressure relief valve. So whenever the vaporizing chamber pressure increases for the specific inhalational agent, the cassette pressure sensor picks up, it releases the pressure relief valve, and it scavenges the inhalational agent through that. So thereby preventing OT pollution and causing a more, by preventing the greenhouse effect. So coming to the gas flow, what is different in Aladdin a cassette vaporizer is that, like any other variable bypass, it has a first split in the fresh gas flow is split into two portions. The bulk of the fresh gas flow passes through the bypass, and a smaller portion through the one-way check valve, and the add-on feature is the electronic inflow close valve that is present in the Aladdin cassette vaporizer. Then it enters the cassette by passing through the one-way mechanical ball valve in the rear panel of the cassette. This cassette inflow valve opens when the cassette is plugged into the slot of the anesthesia machine. The fresh gas flow enters the vaporizing chamber to pick up vapor at the saturated vapor pressure. The gas saturated with anesthetic vapor exits the cassette through the cassette outflow valve and passes sequentially into the electronic outflow close valve, and as a liquid flow, and it also has a liquid flow prevention valve and a proportional flow valve. So this proportional flow valve is nothing like a SORC system that prevents the hypoxic mixture to be administered to the patient. So what I'm actually explaining is coming back to the same diagram, that the fresh gas flow enters through the inlet. The fresh gas flow then hits the fixed restrictor. So some part of the flow gets bypassed. Most of the fresh gas flow gets bypassed, but some gets into the check valve, that is a one-way valve, which enters the vaporizing chamber here, where it meets the saturated vapor pressures, and which is sensed by the pressure and the temperature sensors, and then sends relays into the central processing unit, and also it gets carried out to the outflow through the other limb of the vaporizing chamber, and then gets mixed with the fresh gas flow in the outlet, and then gets delivered to the patient. So this is what it is. So till now it functions as a variable bypass vaporizer. Now, how can it function as a measured flow vaporizer or an injector vaporizer? So here to deliver a requested concentration of a volatile agent as per the dial changes, the concentration control dial, as you change the dial concentration, the outflow from the cassette is controlled by a proportional valve. Hence, the control loop in the system depends on the cassette flow and not the agent concentration, which is delivered to the common gas outlet. Delivery of a set agent concentration is based on the mixer output pressure and the cassette pressure. So when the cassette pressure exceeds the mixer output pressure, the entire fresh gas flow is directed through the bypass chamber and the inflow valve closes to prevent any gas flow to the cassette. So the excess pressure in the cassette is then brought down by metering out some of the gas containing inhalational agent from the cassette pressure relief valve attached to the scavenging system. So what happens really is, coming back to the same diagram, so whenever the pressure within the vaporizing chamber increases, there is closure of the one-way check valve that is present at the opening or the initial limb of the vaporizing chamber. So when the pressure when the valve closes, most of the fresh gas flow just bypasses through the vaporizer. But on the other limb, some of the saturated vapor inhalational agents enters through it to provide a desired vapor concentration or a inhalational concentration, thereby acting as a injector vaporizer or like a diva vaporizer. So that is how it works, both like a plenum type vaporizer as well as a measured flow or an injector type vaporizer. So this cassette, Aladdin cassette vaporizer is also specific in that it has temperature control and temperature compensation. So the vapor concentration of the volatile agent is determined here by the saturated vapor pressure divided by the total cassette pressure. Hence, if the temperature falls, the saturated vapor pressure of the volatile agent also falls, and therefore the proportional valve will accordingly govern the gas flow output from the cassette. Finally, the temperature compensation is achieved by the central processing unit. So that is the break. The microprocessor receives input from multiple sources. These are the major sensors, the pressure sensors, the fixed restrictors, the flow meters in the variable bypass, as well as in the bypass chamber, as well as in the vaporizing chamber, which senses every 200 milliseconds the fresh gas flow rate, the carrier gas composition, the set vapor concentration, the liquid level, and the temperature in the vaporizing chamber, which determines the outflow from the vaporizing chamber and also controls the vapor output electronically. To maintain cassette temperature, there is a fan mounted beneath the Aladdin cassette housing the operator. So since, as I mentioned, there are many convolutions, the surface area increases and there is evaporation. So since evaporation is a surface phenomenon, it causes cooling. In order to prevent this cooling, the vaporizer is attached with a fan so that it warms up the volatile anesthetic and is delivered. So the cassette temperature increases, and so the saturated vapor pressure increases. And if the required amount of anesthetic is high, in cases of high flow anesthesia, which is rarely used nowadays, or in cases of high concentrations which has to be achieved, like in induction in pediatric patients, we require larger amounts. For this, there is a fan incorporated in Aladdin cassette vaporizer. So the difference in the delivery of desflurane compared to other agent is that the desflurane, as we all know, has a boiling point of 22.8 degrees Celsius. So when the temperature of desflurane is less than that, it functions as a flow over variable bypass vaporizer. But when it is more than 22.8 degrees Celsius, that is more than the boiling point, the inflow valve closes and no fresh gas enters the cassette. The vaporizer now behaves, as I've been telling, it acts as an injector, and a calculated amount of vapor is injected in injected in a proportional way through a proportional valve to mix the fresh gas from the bypass chamber. So what is the difference between Aladdin and Aladdin cassette vaporizer and Aladdin 2 vaporizer? So Aladdin 2 is more modernized, meaning that it has better electronics. So it also has liquid level sensor machine. Sensor display, liquid level displays, which are much bigger, and it also has liquid level sensors, so that it can electronically detect the decrease in level of the liquid anesthetic than the visual errors, and thereby decreasing the visual bias errors. And then it also has a locking lever, which is absent in Aladdin cassette vaporizer, thereby preventing the overfilling or the tipping effect that is seen in vaporizers. And it also has a temperature sensor, which is absent, with temperature sensor within the vaporizing chamber, which is absent in the Aladdin cassette vaporizer. So coming to the salient features of Aladdin vaporizer, in salient features, I have also included the safety features. So the Aladdin cassette vaporizer, the vapor output is not influenced by the atmospheric pressure changes, since the vapor concentration is determined by the separate environment, that is the total cassette pressure. The electronic control in the cassette allows for automatic record keeping and usage calculation. And third point is that it is electronically controlled. But this is, as I discussed, is a disadvantage. So when there is a power supply failure, the workstation battery gets depleted, and then the vaporizer fails in delivering the required amount of vaporizer or the inhalational agent. The cassette also features overfill protection and also has level sensors, which are electronic and more accurate than the visual sensing. There is also liquid spill prevention valve that prevents the anesthetic liquid in vaporizing from vaporizing chamber from entering into the fresh gas line, thereby preventing overdose of inhalational agents. There is also no risk of agent spilling if the cassette is tilted, as the inlet valve that are mechanically ball valve spring loaded will close, preventing any spillage during the transport or during filling of the vaporizer. The vaporizer, it also undergoes daily a self-check automatically. So whenever you switch on, whenever you attach the vaporizer onto your workstation, or workstation, specifically the Datex Omida or the ASUS workstations, it as a self-check automatically, saving your time in emergency situations. It also has a pressure relief valve that works as a safety valve that opens whenever the pressure inside the Aladdin cassette is greater than 2.5 bar, or in SI terms, standard units, 1899 atmospheric pressure. So these are the salient features of Aladdin cassette vaporizer, and I've discussed the major concept of Aladdin vaporizer being functioning as majorly as a variable bypass, but at times when the concentration in the vaporizing chamber, particularly when using desflurane, it can act as an injector vaporizer, and this safety mechanism involved in these Aladdin cassette vaporizer. So by this, I end my talk on Aladdin cassette vaporizer. Thank you. Have a nice day.
Thank you, Dr. Gaurav.
Thank you,
Well
sir.
explained all aspects of Aladdin cassette.
Thank you, sir.
1-2 question we will ask after
Yes.
and now the most awaited lecture
Definitely.
today.
Yes.
Dr. Madhusudan, sir.
Yes, ready?
Yes, sir, please.
Gaurav, let me share my screen.
Yes, sir.
Okay. Good evening, everybody. Good evening, everybody.
Good evening, sir.
First of all, my thanks are due to ISA's Pudukkottai city branch, and then my very good friend, Dr. Meenakshi. But at the outset, let me confess that it was only a moment of madness maybe when we participated in a pro-con session during the race in 2013 when I put up a slide saying that I educate and Meenakshi, my opponent, entertains. I thought it was forgotten, but it actually I realized even in Shillong he mentioned this, and now again I think I apologize if I have hurt you by that, but Meenakshi's entertainment is far excellent. You can't match it. Even when he teaches, there is so much of fun involved. I think it's one of the, it would be very nice to listen to him actually when he delivers lectures too. I don't think I have too much of time left, but I will try to do some justice to the topic given to me, the green OT concept. Basically, when we talk about the green OT concept, it involves a lot of areas, including the infection control, and then how efficiently we utilize the time and resources. And finally, the onus is also on us, the anesthesiologists, to reduce the environmental pollution and use only the effective doses of the drugs. And one of the concepts of the green OT is raising the bar of safety in anesthesia. Therefore, as I said, an anesthesiologist has a major role to play when it comes to the green OT concepts. The NABH in India actually gives you a certificate regarding the green OT concept, and it's always nice to have, other than having NABH, NABL or NABB, it's also good concept, and it's very good to have green OT certification by the National Accreditation Board. Therefore, you can consider this as a prelude to everybody to be prompted or provoked to have the green OT concept certified, green OT certified complexes in the hospital. Anyways, the previous two speakers have extensively spoken about two exam questions basically, and what I am going to speak about is how you can improve your practice and how on a daily basis how you can make a change to your practice and to the environment. Let us confess that a lot of the quality indicators are basically moving towards the green OT, as I said. And we should also look at low flow and compound A, which basically prevents us from going towards the efficient use of the inhalational agents when you start anesthetizing. All these topics are basically, they are connected to each other when it comes to reduction in the greenhouse gases being emitted from the OR complexes and reduction of them. In the year 2010, we made a commitment, anesthesiologists world over made a commitment to reduce the emission of greenhouse gases by about 50% in the year 2015. That was long gone. I don't think we have made that much of a difference, but I don't have the data to say that we haven't even tried reducing the greenhouse gases being released from our ORs. But there are a lot of things which as anesthesiologists can contribute to reduction in the greenhouse gases. We will see how we can help out. Dr. Sumesh has already given a brief summary of the inhalational anesthetics when they were invented, when they were put to use, and how most of them faded away, and we are just left with a few of the inhalational agents like isoflurane, desflurane, and sevoflurane. There might be some centers which still use halothane, but I think gone are the days for us to use the outdated halothane, even if you have the vaporizers. Funnily enough, the first ever inhalational agent which was used was nitrous oxide, and till date it exists in use. Though nitrous oxide, this is one of the point of contention. If nitrous oxide is obsolete or not, this is where in 2013, I and Dr. Meenakshi Sundaram fought out during the race. And nitrous oxide, it's interesting to remember that diethyl ether was used in the year 1846, demonstrated for the public view in 1846. And then nitrous oxide was used during the public demonstration in the year 1844. But still, nitrous oxide, though is a good analgesic, was touted to be a humbug. And after the public demonstration of diethyl ether, the dean of Harvard Medical School looked at the audience and said, ladies and gentlemen, this is no humbug. But as I said, interestingly, nitrous oxide is still being used, and the no humbug drug, diethyl ether, has long gone from our practice. Anyway, most of the drugs, because of the side effects, because of the complications it could cause, and mostly the fluoride ions, which can cause nephrotoxicity, they all went out of our practice. And as I said, sevoflurane, desflurane, and isoflurane are still being used mostly in our practice. How do we reduce the carbon footprints? As I said, we have a commitment, and to save the environment. We all know that the greenhouse gases, whether it is from your refrigerators or air conditioners or motor vehicles or our anesthetics, they all are greenhouse gases, and they increase the size in the ozone depleted hole in the stratosphere. And as this paper, the Hindu said, we had long ago in the year 1700s, we had about 280 ppm of carbon dioxide concentration in the atmosphere, and it has gone up to about 400 parts per million. And it's quite a bit. And the onus again is on us to reduce that. And as I said, anesthesia gases, when you start reducing the use, or you reduce use efficiently, the ozone depletion might come back, but go down rather. But let us also remember that 2015 onwards, the studies say that the ozone layer repletion is happening and it is closing. The hole in the stratosphere is actually closing. Therefore, it should be, we may rest well even after using our greenhouse gases, but still, I think as the responsible citizens, we should be working towards reducing the carbon footprints or reducing the environmental contamination, as these two papers say. Basically, my first half of my lecture depends on these two papers, which appeared in the year 2010 in Anesthesia and Anesthesia Analgesia. The first one is about the global warming potential of inhalational anesthetics. And the subsequent slides, I will tell you in detail how exactly we can reduce that. And we can also reduce the fresh gas flows, and we can reduce the environmental contamination. Please remember that just by having a scavenging system in the OR, you are only releasing the harmful greenhouse gases into the environment from the OR environment, but it will be in the environment. And it is not a good concept just to have a scavenging system and safeguarding your interests inside the OR complex, and whatever happens outside the OR complex is none of your concern. It should not be, right? As I said, most of my info has come from these two papers. Please remember, anesthetic gases actually heat the climate as much as 1 million cars do. And we tend to believe that anesthesia is not much, and it's mostly in bigger centers, but still, whatever we do, if we don't use the gases diligently, it can heat the climate as much as 1 million cars do. This is from way back 2010. The number of surgeries, number of anesthetics would have gone up exponentially from this day. Therefore, the harm we cause to the environment would have only gone up. 1 kilogram of anesthetic gas affects the climate as much as 1,620 kilos of carbon dioxide. It's worth remembering. Therefore, let us start reducing the use of inhalational agents. I talked about two terms. One was the global warming potential of inhalational agents. In this chart, just look at the encircled lines, columns. Whereas propofol, we haven't been able to tell how much is the global warming potential of propofol. Basically, this is calculated from the moment the drug or the agent is manufactured and it is transported, and the trucks how much they are environment friendly, and then how we use and how we release the inhalational agents to the environment. Therefore, even propofol, it may not be released into the environment as such, but production and transportation of propofol also has a lot of global warming potential because of the energy used and pollution created by the production units. But the global warming potential for 100 years is, for sevoflurane, it is 130, isoflurane, it is 510, and desflurane is 2,540. This is basically when you look at 1 MAC of the inhalational agents with the fresh gas flow of about 1 liter per minute. But sevoflurane, when I talk about this paper from July 2010, we are still looking at 2 liters of sevoflurane fresh gas flow, because it was widely believed that you cannot use less than 2 liters of fresh gas flow for sevoflurane anesthesia because of the worries of compound A formation when you reduce the fresh gas flows. We'll also talk about that in a slide or two later. We can still use much lesser than 2 liters of fresh gas flows for sevoflurane, or you can go down as much as with the desflurane or isoflurane. You can go down to even metabolic flow. You don't need higher flows. Even when you use 2 liters of fresh gas flows for sevoflurane, the excess gas which is released into the environment, and comparatively, is when you reduce the sevoflurane fresh gas flow with sevoflurane to say 1 liter or even lower, the numbers, the 130 global warming potential will come down further. But still, comparatively, desflurane warms much higher than the sevoflurane or the isoflurane. Please remember that. I totally agree with Dr. Sumesh when he said desflurane is prohibitively costly and it cannot be used in an Indian scenario when every expense is passed on to the patient. But still, we should not be using that particular agent only for the reason that, according to me, because of the environmental pollution it causes. And the other point which you can remember, or which you should remember, is the lifetime of each of the inhalational agent. Before we go into the global warming potential for 20 years, you look at the lifetime, tropospheric lifetime of a inhalational agent. Sevoflurane stays in the environment for about 1.2 years, whereas isoflurane for 3.6 years and desflurane for 10 years. And nitrous oxide stays for as long as 114 years on this earth. But please remember that nitrous oxide, more than 95% of the nitrous oxide basically is released from the earth, Mother Earth. When the legumes, they release a lot of proteins, and legumes release a lot of, and every time the earth dries and then there is rains, the nitrous oxide is released from the earth because of the reaction between the proteins released by the legumes and then the rainwater. Therefore, we don't contribute much to the environmental pollution as with the nitrous oxide compared with any other agents. But still, as far as we can, we should be able to reduce the use of nitrous oxide so that the agent the inhalational agent which stays on the Mother Earth or the atmosphere for 114 years, I think it's our bounden duty to reduce the use of nitrous oxide or release of nitrous oxide into the environment. Comparatively, the global warming potential for 20 years of inhalational agents is compared here. Carbon dioxide is considered as 1, CO is 349, isoflurane is 1401, desflurane is absolutely, it's much more than 3 times, 3714, and nitrous oxide is as little as 289. It is lesser than even CO fluorine. But please remember, as I said, whatever we can contribute, maybe a minuscule amount to save the Mother Earth, I think we should be able to do this. I want all of you, including the postgraduates, to remember this chart, because how long it can stay and how potentially harmful the inhalational agents are to the environment. How can we save the environment is by using low flow anesthetic and try to avoid nitrous oxide. Without nitrous oxide, obviously you can give anesthesia. There are a lot of centers which don't use nitrous oxide anymore in their clinical practice. Therefore, you shift towards the low flow anesthetics and then no nitrous oxide in your clinical practice. Why the low flow is because of this. Again, this chart is from July 2010, but that is when, as I have already in detail spoken about the fresh gas flows for CO fluorine as 2 liters, but now we have come down to metabolic flow with CO fluorine also. Therefore, what we release CO fluorine into the environment, even at 1 Mach of exhaled CO fluorine, is much lesser compared to this 2 liters of fresh gas flows, what is shown in the chart, right? When you use 2 liters and 2% of CO fluorine, what you use up is about 20 grams per hour of CO fluorine, and 20 years global warming potential goes up to 349. And the other terminology, what I said was 20-year carbon dioxide equivalent. That is another measure to tell you how efficient the agent is. It is 6,980. Please remember, again, the numbers would come down when you change the fresh gas flows to much lower. When you use 1.2% isoflurane and the fresh gas flow is as low as 0.5 liters, it's still global warming potential is about 1,401, and the carbon dioxide equivalent is about 3,881. It obviously goes up exponentially, and when you use 2 liters of fresh gas flows and 1.2% of isoflurane, without knowing how much is the Mach, it could be CDE, could be carbon dioxide equivalent, could be about 15,551. And the CDE ratio is about 2.2 compared to the CO fluorine, 2.2 times, right? And when you use 6% desflurane, and that is what basically the desflurane manufacturers talk about, 0.5%, you can go as low as 0.5 liters of fresh gas flows, whereas with CO you cannot, but it's disputed, and now we know that you can. The global warming potential for 20 years is 3714, and CDE 20 years carbon dioxide equivalent is about 46,000, and again it goes up to 4 times that when you use 2 liters of fresh gas flows with desflurane. Therefore, when we have any concern for the Mother Earth and the environment, let's keep away from the inhalational agent which causes the maximum. By no means I am advertising for CO fluorine manufacturers. It's only with evidence, right? Therefore, it's our bounden duty, as I said, to reduce the global warming from anesthetic agents. As much as we can, we should be able to reduce the use of inhalational agents in our anesthetic practice. But you may ask me, can we move towards TIVA? TIVA has its own limitations, and I'm not here. I will not be discussing about TIVA versus low flow anesthetics, but TIVA is not the answer for all the mishaps because of the inhalational agents. Nitrous oxide is a dreaded agent, if I can call it so. But the thing is, I've already spoken about it. Nitrous oxide, we only contribute a minuscule amount of nitrous oxide into the environment, but still let us reduce the use of nitrous oxide and let Mother Earth take care of the nitrous oxide released from the earth itself. Inhalational agents are damaging, obviously, and the evidence says that sevoflurane is the least damaging, and we should, even if you don't go for the green notice certification, I think we have to reduce the environmental damage, and we should look at well-calibrated vaporizers and use only the agents which are used up by the body and not released into the environment at all from the closed system. And I will just cover up a bit of low flow and the compound A, the myth, and then I wind up my lecture. And low flow anesthesia, obviously, as I said, we can all contribute. Ultimately, what you have to remember is we need about 250 ml of oxygen per minute. And we need less than, if at all you use nitrous oxide, we need less than 100 mils of nitrous oxide per minute, because nitrous oxide is either metabolized in the body to an extent, and or it is released into the through the intact skin as such. Therefore, could you please mute yourself? Someone was talking. When you talk about low flow anesthesia, I talked about the metabolic flow, where you give only the 250 ml of oxygen, which is used up by the body in a closed system, completely closed system, and then you add the inhalational agents which are used up by the body to titrate to 1 exhaled mac of sevoflurane. Now we will restrict to sevoflurane, because people are worried about the less than 2 liters of fresh gas flows. Can it cause release of compound A and then the resultant nephrotoxicity, which is actually not true. What are the advantages of low flow? Basically, before I go into compound A, it's less wastage, less expensive, it's quite safe, and it gives you steady state anesthesia throughout, and then it doesn't keep on changing. The warmth is maintained because of the closed system. The absorbent remains moist and planet friendly. And ultimately, the rest of the things, we will say they are the byproduct, and planet friendliness is the important aspect today. These are the myths, basically, the hypoxic gas mixtures and inadequate depth of anesthesia. When you have a respiratory gas monitor, obviously these things will not happen. And then if you don't have that, you try to download the Gasman app from the web, and then you can use it. You will exactly know what exactly happens to the inhalational agents from the moment they are delivered into the patient's lungs. Therefore, it's not possible to have hypoxic gas mixtures and inadequate depth if you have the proper monitoring ready. All right. What is compound A? It's basically a fluorinated vinyl ether, and you have two, compound A and compound B. Compound A is basically PIFE, that is pentafluoroisopropanyl fluoromethyl ether. You can conveniently forget the expanded terminology. You can just use PIFE. And the compound B is PMFE. This is pentafluoromethoxy isopropyl fluoromethyl ether. Compound A and compound B both can be harmful to the kidneys of the patients if it is if sevoflurane is not used diligently, as was thought earlier. All right. But it basically is released because of the reaction between sevoflurane, carbon dioxide, and the soda lime. And for this to happen, you need a couple of things. One is the desiccated soda lime increases or worsens the production of compound A or compound B. And the other one is you need an enzyme called beta lyase to convert the, okay, we'll come back to that later. Beta lyase basically in the primates or even before in the mice, it makes sure that there is a release of compound A to about 150 parts per million per hour to 1000 parts per million per hour, according to two different authors. Whereas our elders, the primates, they produce about 800 parts per million. And in human beings, in spite of more than 85 million patient exposures, we haven't been able to establish significant nephrotoxicity. That's basically because, as I said, the beta lyase enzyme is 10% lower in human beings, and we can't produce the compound A, which is harmful to the kidneys of the human beings. Even in desiccated soda lime being present or on the weekend, as a first case of the beginning of the week, the compound A formation is not significant in human beings. Please remember the primates produce about 800 ppm per hour and the mice about 1000 ppm per hour. Whereas the human beings, in a small study though, numbered 16 subjects, the average inspired compound A concentration was 20 plus or minus 7.8 parts per million, even at the end of 5 hours of anesthesia. It does not happen, as I said, because of the enzyme beta lyase, which we are deficient in. It's about, according to one study, it is about 20 to 30 times higher in rats than in human beings. The beta lyase is needed to convert the compound A to a reactive thioacyl fluoride metabolite that is toxic. All right, we are deficient in beta lyase, therefore we will not produce that much of compound A to damage the human kidneys. All right. Then in continuity for green OT concept, as well as to reduce the use of inhalational agents, you have to have the monitoring to monitor the depth of anesthesia. DOA is something which is needed to prevent the awareness during anesthesia, but I'm not going to talk about this. But monitoring the depth of anesthesia will also avoid the unnecessary use of inhalational agents. You have the exhaled MAC and you have the depth of anesthesia monitored with entropy or BIS. I think that will be much, much safer, right? And it is worth going through this because one of the more common reasons for litigation against anesthesiologists is awareness under anesthesia, and that has to be prevented at any cost. All right. And how do you prevent awareness is keep the patient's depth deep enough with inhalational agents, only adequate amount of inhalational agents. And then we should have good monitoring systems and good workstations. That is how we become quite safe when it comes to the anesthesia delivery and saving the environment. For the green OT concept, you need to have all of this, including a good anesthesia machine. All right. This is how you can reduce the pollution and inadvertent use of inhalational agents and polluting the environment and harming the ozone layer. I think I wind up here because we have gone past the time given. Thank you very much for the patient hearing, and thanks again, Dr. Meenakshi and ISA Pudukkottai for giving us this opportunity to take you through something which is very relevant to the postgraduates and relevant to everyone who practices anesthesia. Thank you very much. Am I the only one here now?
Dr. Iyer, sir, here. Yes.
Oh, yeah. Thank you very much. Meenakshi hasn't left.
Sir, please unmute, sir. Iyer, sir, please unmute.
It's an excellent talk, sir, regarding the green OT concepts. And you had well explained that we can make a green OT by using or not using low flow anesthesia that can be used with inhalation anesthetics, and we can avoid the nitrous oxide, so we can able to make the atmosphere pollution free. And new things that I came across is compound A. Till now we are afraid of compound A, and you had give the logic that the lyase, beta lyase, that is less produced than the primates and the rats. I think it's new thing to me and everyone, because we are afraid of that compound A, it will cause so and so. And no doubt you had well mentioned that along with use of low flow anesthesia, we have to use monitoring, and we can avoid the awareness, as you had mentioned, sir. There is one question in chat by Dr. Kanan that you had given answer also. What is other option for nitrous oxide?
We tend to use a combination of air and oxygen during most of our anesthetics. But even otherwise, when I said you use metabolic flows, it's only 250 ml of oxygen which is used up by the body per minute is replenished. You supply only 250 ml of oxygen and no air too there. When you have an absolutely closed system with you, you can use only 250 ml of oxygen. You don't even have to use air combination there. Otherwise, if you want to use, say, 0.5 liters of fresh gas flows, use 250 ml of oxygen and 250 ml of air. That's ideal. I know that we are worried about the MAC, and 50% of the MAC, when it is contributed by the nitrous oxide, we believe that we save a lot of money by way of using excessive inhalational agents. But I think when you look at the environmental hazard, and nitrous oxide is not an agent which doesn't have inherent problems. Obviously, the first things what we learn when we learn anesthesia is the hazards of nitrous oxide. I think time has come for us to get nitrous oxide out of our practice to save the environment and save your patient too. Therefore, use air-oxygen combination, or you just use metabolic flow of oxygen.
What about xenon, sir?
Xenon, basically, I know it's a very good option. I think only a couple of institutes in India had xenon when it was brought into, but it is prohibitively costly. When we say desflurane is costly, it is 10 times more expensive than desflurane. Therefore, I don't know, even the biggest of the corporates, I don't know whether they can afford to use it. But xenon obviously is a good option to use.
Along with oxygen and gas, as you had mentioned, we are using inhalation anesthetics. And for analgesic profit, we can switch on to the opiates.
Then there will be somebody who comes and talks about opiate-free anesthesia.
Yeah.
No,
But
I think I don't know. I am still a diehard fan of opiates. I don't think in India we have any addiction reported because of our intraoperative or postoperative opiates, just like what has come from the Western world. But I think opiates have a role to play in our anesthetic. With due apologies to Tushar, who talks about OFA all the time. I think.
See,
I think
actually, what I also feel, the opiate-free anesthesia is only a university question for the postgraduates.
yeah, I agree.
Otherwise,
Paper 4.
it has to be there in the field in
Yeah,
India.
Yeah, I agree. Totally agree.
We have to include the armamentarium in our practice with pro cons, which is one is the best or combination of the drugs. Thank you very much, sir.
Thank you so much.
Yeah.
No questions.
Dr. Gaurav has mentioned the magic with the Aladdin, as name suggests. I have not came across because of we are not having this gadgets. He has well explained all the things. Sir, I think you are having this vaporizer.
No, we don't have.
Okay.
Even I want to say, just to see the vaporizer, I traveled to Pondicherry and I have seen it in Mahatma Gandhi Institute, because I want the postgraduates to travel, because everything will not come to their doorsteps.
Correct.
That is the idea of the question will come, but the vaporizer will not come. That is the reason why I said it is not Pudukkottai alone. So many areas it is not there, but questions will come. So you please go and see, or in the conference you see, they will be having, they will be very much willing to teach. This is a message for postgraduates. I traveled to Pondicherry just to see the ISIS machine.
I like this statement. Yeah. People have to see, go and see.
So they said it costs 45 lakhs, sir. Who will buy?
I know.
They said it is 45 lakhs.
I know. It's very expensive.
The machine is incorporated with artificial intelligence also. So the AI also we have to read. So the more development, more we have to read, more stress we cannot enjoy. Dr. Venkatagiri, what is your opinion? Kasaragod will not Aladdin vaporizer.
He will get.
No, Aladdin vaporizer. I have only take 7 vaporizers. That is okay. But in green concept, whether we are now going back from the disposable to reusable old green clothes and all, because somewhere they have touched that also, because we have to reuse instead of dispose. Going for the lot of plastics are being used now in the OT and all. Stop
Correct.
that use of plastics, cloth and all these things.
Yes, right. But the argument against it is they say when disposable linen is reusable linen is used, they talk about the laundry, they talk about the power used, they talk about the detergents which are not environment friendly. They talk about the water which is a huge resource not to be wasted. That's why they say the disposables are fair enough, relatively.
Disposable is another marketing strategy by the companies.
Yeah.
Meenakshi is an administration, he will look all these things.
Yes.
No, it is there. It is a hidden agenda.
Yeah. Nice. Anyways, we had a nice session.
Sir, if no more questions, Dr. Raigar, sir.
Yes, sir.
There is no more questions, sir.
No, not in any chat, sir. Yeah.
See, before I give it to Dr. David for formal vote of thanks, sir. Today I am very happy because it had happened as a friendly chat, and this so much of a discussion was on Aladdin and this green OT. As one is not seen, another is coming up. But Dr. Sumesh, I want to mention one thing. See, the MAC, so far I have read, so many times I have set the question paper as MAC. As a PG also I have seen as MAC. But today I had a clarity on this MAC. So I personally thank Dr. Sumesh sir for this wonderful way of explaining MSc. Really, it is a good concept. I will again see it in the YouTube. And Dr. Madhusudan, I have left one thing in the introduction. He is one of the handsome anesthesiologists in the entire country. Another one is Venkatagiri, he is also there. So these people, that is a best thing. And our youngster,
Venkatagiri is like
he
that
is very good.
orangutan which you are holding. That
Satyavardhan,
in your this thing, huh? That
Satyavardhan
you
is
are
holding.
holding.
No, but as they are nearby Mangalore and Kasaragod, I think both are unique. And in spite of two handsome people, they are good friends. That is another point. So now I request Dr. David to propose the formal vote of thanks. He is our treasurer.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I'd like to thank our academic chairman, Dr. ALM, sir, for conducting 38th webinar. Thank you very much, sir. And special thanks to Dr. Lalit Kumar Raigar, senior professor, principal and Government Medical College, Sirohi, Rajasthan, for sharing his experiences. Thank you very much, sir. And I would like to thank today's speakers, Dr. Madhusudan Rupatya, professor, and Dr. Sumesh Rao, professor, and Dr. Gaurav Satyavardhan, resident from Kasturba Medical College, Mangalore, for making excellent academic session. Thank you very much, sir. I also thank other faculties and postgraduates and Akirullah and A1 Logics for technical support. Thank you all. Thank you very much.
Thank you.
Thank you.